Hello, good afternoon. I am Jarne Verhagen. I'm a PhD candidate at Ghent University, EMAC and ID Lab, where I do a PhD in hybrid and causal AI for healthcare applications. And today I'm going to present causal AI in healthcare. But before I start my story, before I start my talk, I have a little story actually. So recently, a couple of months ago, I went to my physician, and during the regular checkup, she asked what I did for a job. And yeah, we started talking. I said I was an AI researcher, PhD candidate, doing some healthcare applications. She got interested. But then she started actually criticizing AI. And she said that AI is only using correlations. Like they can't do anything with it as a physician. Furthermore, these models that are created are black box, not interpretable. And if they give it to her, for example, she can't do anything with it. It just spits out a prediction, and that's it. It's useless for them in a kind of way. So I was really triggered by the response. At that moment, I had to say, yes, you're right. These models are not interpretable. These models are only built on correlations, and my answer stopped there. But today, there is something different in my answer. Today, I would say that, yes, you can find causality with AI. You just have to approach it from a different angle. Okay, today I'm going to present why this is my answer right now. Let's digest the story. Why did she say all those things about AI, like interpretability, lacking, and correlation? So let's focus on these 2 points. The lack of interpretability in AI and only built-in correlation. Are these things true? Well, let's first start with the definition of interpretability. Interpretability is the degree to which a human can understand the cause of a decision. Sure. Okay, what can we do with that? We want to reason in it. We want to understand what someone says. So what does a model do? Well, this is what a model does. It just spits something out and it's just nothing. Why? Just black box. There are some white box solutions, but most common models, such as even the popular ones like the large language models, these are all a black box. So they say AI is a black box. Question is this actually a problem? Well, there has been some studies done on this, and one study in Brazil really intrigued me, where they say that user trusts in black box machine learning models, where they analyzed this, and one of their findings said that this is actually not a problem. And even adding some explanations to these black box models did not diminish the trust in these models. This is interesting. But why do we still have the feeling that transparency and interpretability is important for these models? Well, this is because transparency in a decision enables reasoning. Well, if I would say to you that you have to do that task, and you're thinking, okay, this is not in my job description, so you're saying why? And I say, because I say so. I don't think you're really satisfied with that answer. The same thing is with a couple of these AI solutions. We want an explanation, just to reason it. Even though we would not agree with the reason, we can just reason with it, and we can satisfy the task, we can satisfy this decision. Okay, this is one point of her argument. The second point would be the correlation part. And maybe she's read this article on Forbes where they say that our entire AI revolution is built on a correlation house of cards. And if one card falls, the complete AI world crashes. Well, we've recently seen that it's not crashing, it's booming. But why this quote? Well, Let's start with the first thing. Correlation is not causality. It's one of the most common things that's said about correlation. But why is this also a problem? Well, it first starts with the static aspect of correlations. Because correlations are just observations, associations at that moment. If the world changes and your model is built on these correlations, your model will not generalize enough. It will not be adaptive enough. Yes, you might have a model for today, but it might not work anymore for tomorrow. But what exactly does this mean? Correlation is not causality. Why is this such an important topic? Well, one of the things is called spurious correlations. And this thing really intrigued my interest, where the total revenue generated by arcades is highly correlated with the amount of doctorates awarded in the US. I can assure you, I haven't been to an arcade once in my doctorate of computer science. So I don't know about this one. Maybe I'm wrong in my doctorate, but this is potentially a spurious correlation. But another example that's more health related would be this one. Suppose we have a blood pressure medication, and this blood pressure medication, we want to analyze its effect on mortality, for example. We take a lot of people that have taken this blood pressure medication and then compare it to those who do not take blood pressure medication. And then you can see that blood pressure medication kills people. Well, depends on who you look to, because there is something going on here under the hood. Because people that take blood pressure medication tend to be generally older compared to people that do not take it. And to my knowledge, older people tend to die a little bit faster than younger people. So this age factor is called a confounder, and this confounds and skews your results. But this is really important. This is one of the core aspects actually of causality versus correlation. Let's go back to the real foundation. What is causality exactly? Well, I typed this in Google, and this is the result. Causality is a relation between a cause and an effect. The difference to correlation is that the correlation is just a relation existing between phenomena that we see, while causality has a cause and influences the effect. Or an example to really specify this, suppose we are already taking our blood pressure medication, and we take it and then we see that our blood pressure reduces. So it works, it does its job. That's good. That's cause effect. The other thing, I'm taking blood pressure medication, and I have, for example, a partner that's really keen on making me take the blood pressure medication. So my partner keeps reminding me to take the blood pressure medication, and this is because I need to take blood pressure medication. So cause, effect. But then we see, if we would analyze those results, that, for example, every time my partner reminds me to take blood pressure medication, my blood pressure reduces. Well, this is just a correlation, not a causation. Would be interesting though, but would probably have the other effect if it's only that. So this is the difference between correlation and causation. But why do we need causality, especially, for example, healthcare or in the AI industry, or as humans? Well, let's go back to the transparency, because causality enables reasoning. And we as a human, we want to make decisions and predictions using reasoning to understand the mechanisms leading to the change that we will do, the change in our behavior. And this is called real causal reasoning. And we do it all the time. We do it every day. For example, if you're sleepy and you have a deadline this afternoon, so you drink a lot of coffee to get an adrenaline boost to go through the sleepiness, and then maybe get your deadline. Or the other thing, if your partner keeps reminding you to take blood pressure medications, well, you will take it you will take it in advance to avoid the discussion. Or if you're going to a hospital, you have really a bad stomachache, you have appendicitis, you need surgery. Because if you don't, you might even die or go to intensive care, which is a really not fun experience. So we use this every day. This is a way of thinking, often subconsciously, but we do it. And there was this one person, this computer scientist called Judea Pearl, that formalized this in his ladder of causality. And it has like 3 steps. It's a small ladder, but it's enough. It starts with seeing. What we first do is see around us. See things happen. For example, an apple falls from a tree. We start to associate things with it. So, which symptoms explain a disease? But then we have the next step. Because seeing is only, for example, what animals mostly do, and that's their limit. We go beyond. Because we start intervening in the world. We start doing things. For example, we take the apple and we throw it in the air, and then we see it comes down again. Or you start asking the question, if I take the aspirin, will my headache go down? And this is the concept of experiments in physics, the empirical science. Because we want to eventually reach to the last step in the ladder, the imagining step. Because what does this do? This lets us imagine about the things that happen around us, the counterfactuals. Because you can ask then the question, if I would not have taken an aspirin, would my headache still go away? And it is this counterfactual aspect that is the core of causality. And you can formalize this indeed in this kind of graph. This is called a causal graph or a directed acyclic graph. But there are still some difficulties in formalizing this causality. Because first, we need to explain how to find these confounders and also find the direction. Because it might be that if you take blood pressure medication, you get older. So blood pressure medication is the cause of getting older, which we know is not the truth, but it could be. So we need to find the direction of this cause. And also there are a lot of unobserved confounders, especially in the medical world, because medical science and the medical world is so complex. Often the real world is so complex. There are so many confounders that skew our results and skew our solutions also. So we need to take this into account. And what are the applications of causality? How do we use it? Well, the first thing that comes to mind, especially in healthcare, are the clinical trials. And the main method, which is the main method to find causality, randomized controlled clinical trial. What does this do? So it takes a set of people, selects them, and it splits them randomly into 2 subgroups. 1 for treatment, 1 for control. And then it just, after 6 months, they wait, they see what happens, and they take in the results, they note it down, and then they subtract it from each other to see the effect in the clinical trial. But one of the most important things here in this kind of study is the randomness that is generated by just randomly assigning a treatment. If you don't, you will have skewed results. You will have your confounding again. And also selecting people, because if you don't have enough people in your clinical trial, you lack generalizability, which is also a problem. So are clinical trials then the solution to everything? Well, they can do a lot, but because we're not doing it, the answer would be probably no. But why? Well, let's take this example. Suppose we did a clinical trial and we did not compensate for age, but we just measured it. And then we see that this is the treatment effect. We see if you're below 50, for example, blood pressure medication in our example, I would not advise you to take it because it has a negative effect. And if you're above 50, it has a really positive effect. But if we then aggregate all the results, we see that it has a negative treatment effect. So it's bad for you, while there's a lot of people that has a potential benefit. Well, it can be explained by the distribution behind the trial. Because here, a lot of younger people were included that have a negative effect. As a result, your outcome is negative. So this is also something to keep into mind. And the clinical world isn't the only one that does these clinical trials. Like these big companies, Meta, Google, TikTok, all these, they also do clinical trials, or the concept of clinical trials. Sometimes they call it A/B testing, sometimes it's more really randomized trials, where they use this concept of randomly assigning a treatment, or for example, for Meta, randomly assigning an algorithm to one of the user groups, and then afterwards measuring the effect. In theory, it's the same concept, it's measuring causality, but here in these companies, they're just randomly assigning, not specifically selecting users, while in the clinical application, they're really trying to test a hypothesis, selecting the specific patients to specify and precisely find the causality. So what are the problems then for these solutions? One, the first thing is selecting people. If you don't have the correct people, your results will be first skewed, will be not correct, or just lacking. And this is also a difficulty. This also increases with cost, because clinical trials are very expensive. They also tend to fail often, which generates more cost. And eventually, for example, you did your clinical trial right, you have a good set amount of patients, you have a good solution, you see your treatment, your medication really helps the people. And then a pregnant woman takes her medication and she dies. Okay, what's the problem? Well, you did not include pregnant people because of ethics. Well, that's also a problem of clinical trials because, for example, if you go to intensive care and you want to test whether ventilation increases the risk of heart failure, you cannot just randomly remove ventilation from patients that need it. It would not be really ethical. And I would not advise it. So these are already limits of clinical trials. And if you go one step further and go to personalized healthcare, so on the person with genetics, we cannot do a clinical trial for every single genetic gene and have that solution. Well, it's possible, it would just cost a lot of money. Okay, that's one part of the applications. The second use would be explaining, for example, to your patient. Why does X work? Why does X get predicted? Well, let's take our example of blood pressure medication. So I go to my physician and I have a history of high blood pressure. And the physician says, well, I would advise you to take blood pressure medication. Okay, but it really rings a bell in my head because I know at home, my partner still keeps reminding me to take medication when I have it. And it gives me stress. So I don't really want to take medication if it's not needed. So I ask, why do I need to take this medication? Will it help me? Well, they explain, yes, it will reduce risk of heart disease, reduce risk of stroke, make your life potentially longer. So it's good. Then you need to weigh as a patient, is living longer more important than having arguments at home? And you can do the balance yourself. And this is one of the key aspects also of causality. Explaining your solution, explaining your decision, and eventually also explaining your AI. And the third aspect would be fairness, because it would be really unfair to compare the athletic ability of a 3-year-old to an 18-year-old. I think we can all agree that the 18-year-old, if they're both healthy, will be probably better than the 3-year-old. But the same thing happens in a lot of other applications where they compare things that should not be compared. And with causality, you can find this. And there's a really fun paradox for this. A guy named Simpson, not this guy, but a guy named Simpson found this. And it's called the Simpson paradox. Let me explain it. Suppose we have two different medications. Blood pressure medication A, that's generally prescribed to younger people. Blood pressure medication B, that's generally prescribed for older people. And we analyze these medications, and then we see two different things. We see that, for example, the medication A has almost for every age a better effect than medication B. So medication A is a solution. And we aggregate the results, and we want to see how much medication A is better than medication B. We aggregate it, and then we see that medication B is better than medication A. So at the same time, medication A and medication B are the best. So that's a paradox. That cannot work. That's impossible. Only one can be the best. Why is this the case? Well, if you look back at the distributions, we see that mainly young people got medication A, and their effect is a little bit lower compared to the older people that get medication B. And this creates a paradox. This creates the skewness. And this is a result of fairness. And these concepts can be applied to many domains, from governments to call centers, to job coaching even, to treatment estimations, to all these other solutions where you need to apply these three concepts of trials, explainability, and fairness. But this talk is about causal AI for health, and I haven't been talking about AI that much right now. So what does this do? What is it? Let's go back to our ladder, the ladder of causality, and there we see the doing part. And this doing part can be associated with prediction, because we ask ourselves the question, what if I take the aspirin? Will my headache go away? We can create a model to predict this. The same thing can be said for multiple others of these models. But we want the top part. We want the causality. We want the counterfactuals. We want the effects. So there we can leverage AI, because AI and machine learning, they take in a lot of data and they put it into their models, their black boxes, the white boxes, depends what you want to use. And they can find predictions, they can find structure, they can do analysis in large data sets with complex structures and automatic discovery for things that we as a human cannot do ourselves. So these models can help us to find also causality. There are a couple of methods to do this with supervised learning, where they learn a target to predict, for example, the weather, what the weather will be tomorrow. Unsupervised, where they find structure, and then reinforcement learning, which is just like training a dog, giving them rewards if they're doing something good. But how can we apply the AI with the causality? Let's go back to our graph. There are a couple of aspects here, but let's just focus on the first one, which is the effects of the treatment, or things that influence the treatment assignment. Here this is age. And we do this with propensity modeling. And what is propensity modeling? Propensity modeling is finding the probability of giving your treatment, or here blood pressure medication, to a specific patient. This is related also to fairness, finding bias. How do we do it? Well, you've got your data. You put it in your model, mostly a supervised model, and to train a propensity model. What is your target? Your target is your treatment, is your policy, is a thing that you want to do or want to give to your patient, want to, the job that you want to give to your job coaching. You train it. And then you take a trained propensity model, which outputs a probability of that treatment, for example, for giving a new patient. And we want, for these models, an accuracy of 50%. We want it to be really bad. Because if it's good, that means then there is a really large bias in your data. Because we can predict whether you will get the treatment or not, which should not be the case, especially in causality, because we want a randomness. Because if we don't, things will get skewed. But if it's not 50%, then we know there is a bias. Then we can research this, we can analyze this, and we can see if there is fairness in our data set, if there is fairness in our solution and application. One of the applications here is, for example, in clinical trials, where they do this propensity modeling, or can do this propensity modeling, to see if their trial was successful enough to be random. And if there was something that can skew the results. And if it skews them, we can match the patients as such that we cannot discern whether the patient got the treatment or not. Because if we cannot anymore, then the results will be true, will be truly causal. If not, then there is some skewness. The other thing is to find and eliminate bias in your data set and in your solution. with these techniques. And the thing that we do, for example, at our lab, we try to use these techniques to optimize antibiotic care in intensive units, because many physicians give antibiotic treatments and sometimes too much. And we want to know why they give too much to reduce these aspects, to eventually reduce the chance on antibiotic resistance. So this is what we do in our lab with this propensity modeling. That's one of the applications. There's another one, which is trying to find the effect a medication has on a specific outcome. For example, here, with blood pressure medication, what the effect will be on mortality. This can be done with AI again, with machine learning. This is called treatment effect estimation. And there we try to find the effect of a treatment. Okay, how do we do it? Well, let's go back to our clinical trial. We have our clinical trial where we randomly assign a treatment and a control group, randomly split them. But instead of doing this, we already take available data. And in this available data, there are already people that got treated. There are people that did not get treated. And we leverage this to create a treatment effect AI that can evaluate on a new or the same patient group their effects. So it kind of simulates a clinical trial with observational data, but just data that you have lying around. But how do we then create this treatment effect AI? How can we do it? And what is the benefit? Well, one of the largest benefits here is that we can take a random patient, patient X, for example, put it through the treatment effect AI, and then get a personalized treatment effect for that person. We call this the conditional average treatment effect because it's the treatment effect for the persons that look all like person X. So this goes even beyond and goes to personalized care and personalized clinical trials, or personalized virtual trials. So in practice, how do you, for example, make one of these models? For example, I will explain the T-learner. In a T-learner, you have your data, which is random, which is split in a treatment and non-treatment group. And each of these groups, you put them into a separate model, a T1 model for the treated, T0 model for the non-treated. Okay, now you train your model on a specific outcome. For example, in our example, the mortality. And then you have your trained models. You take a new person and you put it through these models, through both. Because T1 model is a model that is trained on the treated group. So it knows how the patients react on the treatment. The T0 model knows how the patients react without the treatment. And you can subtract them from each other to get an effect, specifically for that person. And there is another technique called an S-learner. The T-learner from twin, S-learner from shared. So what's the technique and the secret here? The secret is that's just a single model. Just you train a single model, put all data in it, but you add a feature, you add a variable that says which treatment the patient got. Then you train your model. If you have enough data, that won't be a problem. But then you take your model and your person and you put it into the model twice. One time where the treatment is set to off or not treated, and one time with the treatment on, so treated. In that way, you simulate giving the treatment to the patient and simulate giving no treatment to the patient. And then you also can have an effect and estimate an effect for this person. How does this visualize, for example, in outputs, etc.? This is then called a response surface. So you have, on your x-axis, you have some data which represents your patient. And on the y-axis, you have outcome, could be risk on mortality. And the treated persons and treatment group would have this solution. And the non-treated would have this response surface. What is the treatment effect? Well, it's the difference between the two. But those that look closely see that there is a part missing of the t equals 0 for x and the t equals 1. This is where the strength sometimes of AI of machine learning can come from. If your model is accurate enough and can infer enough, it can also infer the regions which you haven't seen yet, and then go for individualized and treatment effect estimation for almost every patient that you've seen in your data set, or even beyond, which facilitates this solution. But this is only the case if you include all your relevant data to, of course, for the outcome, but also your confounders. Because if you, for example, do not include your age, things can get skewed again. The same as with an AI. They need to have this information. They need to take this into account when building this. And this is mainly the difference between regular machine learning and causal machine learning. You think about the confounders, you think about the solution beforehand also. And this gives us what I call virtual trials. Instead of doing a real clinical trial, you can just have a virtual one. For example, before you perform your clinical trial, to analyze your data, to analyze your solution. You can do it to find the correct amount of people. You have your observational data, and there you see that you miss a couple of people where your model has difficulty in predicting them. So this can help you get your population. Further, it can reduce costs. It can already do an initial trial to see if you even might fail or not. Because if there's like no treatment effect and you have a perfect solution, then probably in practice, there will also not really be an effect. Or even if it's negative, really negative, then you already know it. And then you can compensate it for it and make sure your clinical trial is as perfect as possible, or really go to a next step. And also generalizability, because you're training a machine learning model, and this can predict things sometimes that they haven't seen, which is really useful for individualized care. And also leverage a lot of data. Genetic data, they have a lot of features, and large big data solutions can all be taken into account in these causal AI models. And what is the state of the art? Well, there are already a couple of solutions here. There are many learners, which are just frameworks, but there are others, like deep learning models, all generally available for you to use. So that was the second application. What is the third application? Well, we haven't talked yet about explaining our solution. So this comes into the causal graph inference also, where we want to try to find this causal graph. This can be done in mainly two methods. One is using domain knowledge. The other one is from the data. And the method that has been used for a couple of decennia is the domain knowledge, where they try to find this causal graph. And in domain knowledge, well, they create workshops where they gather all these people, where they see which ones, what things are causal, what things are not causal, try to find the literature and really get this expert graph really tuned. As a result, you have a really strong solution, really strong causal graph, but this takes time. This takes a lot of money also. And often, sometimes it's not really complete of just not covering the data that you have. So there's another solution that does this from data. There are like causal graph inference algorithms. There are a couple of them, but there is one problem there, and it has to do with eyes. So what does it have to do with eyes? Well, causal graph inference, or finding an explanation in a causal graph, would be like finding the size or the form of your ice cube just using the puddle of water on the ground. I can assure you that is quite difficult. It could be in the shape of a bunny, could be in the shape of a sphere, it could be a cube. There are many solutions for the thing that you're seeing. The same is true for causal graph inference. But what can we do? Suppose that we actually have this causal graph. We can reason with it. We can find causal relationships here. We can visualize them and then try to explain them to the end user, for example, or to the patient. We can find confounders, things that influence our treatments, and eventually use this Bayesian graph, or this causal graph, sometimes called a Bayesian network, also to estimate treatment effects and to also see if your treatment will be good for your solution. or good for your patients. But there are some caveats in these solutions because these models or these algorithms are high complexity and are sometimes limited by the amount of data that you can put into it. Limited variables. For example, there's an algorithm that takes almost 2-3 days to run with only 20 variables because it has to explore all the different solutions. There are many others that are much faster also, but then less correct. Well, suppose we have this one. What can we do with AI models? Well, one of the things is explain our black box model with this causal graph using the SHAP library. The SHAP library is a library that can just explain your model and see how the prediction correlates or is explained by your inputs. But this is just also correlations, just something that they see. But with the causal graph, you can go one step further. You can go implement and see which ones are the cause and which ones are the effect in your data, in your predictions, and even iterate on it. Another thing that you can do is find the predictive variables in your data. What is a predictive variable? These are the variables that influence your treatment effect, influence the outcome. In our example, it would have been the age, where age, for example, if you're higher age, your medication works better. If you're lower age, it works less. And age is a predictive variable here. And well, the other thing is the counterfactual explanation, something that we as a human like. Can also generate this with your AI model. But how can we do it? How can we start with this? Is this actually already possible, or is it just some theory or some from literature? Well, there are already quite a lot of libraries for you, open source. And for example, for the causal graph inference and analysis, you have CDT library, PyGAMPy, DoY from Microsoft, like the big firms are creating also these libraries and putting them out to the public. For treatment effect estimation, you can use sklearn to create your model and then use a causal lib to have all these learners and to find your treatment effect, and also some propensity modeling. And for fairness and confounder finding, you can also use sklearn, causal lib, but then also use feature selection algorithms to find these confounders, to find these solutions, these variables that influence your outcome, such as PowerShop. So in the end, these are then 3 applications of causal AI that answer the problem that we had in the beginning, the lack of interpretability of causal AI and only built on correlations. So this all supports my answer that I should have given to my physician in the beginning of my story. That yes, you can find causality with AI. You just have to approach it from a different angle. And then I believe you can do it. Thank you. Yeah, one of the biggest uses is, for example, in call centers, where they want to find the correct person to call. Because if you call the wrong person, you're awakening a sleeping dog that just gets angry and cancels their subscription or just doesn't buy anything anymore. So you can use these models to find the correct person to call that will buy your product and that will not waste your time. That's one of the things. And the other thing is in many of the companies that do policy evaluation. If you have a new policy that you want to put out, you evaluate it on your data beforehand, before actually doing it, or in real time, where you evaluate it in real time to see if your policy works or not. So mainly the economic business is doing this aspect, but in healthcare, it's severely limited. And almost no one is doing it right now. Mainly because the healthcare sector is a much more complex situation. That's one of the biggest reasons. And also there's a lack of data there, because without that much data, it's more difficult to find the confounders. If you have, for example, only 500 samples, but that's really sparse, it's difficult to find these confounders. It's just already difficult to create an AI model, let alone create a causal AI. So that's one of the things that hampers the solution there. But if there is enough data, which sometimes there is, you can actually go that one step further and create those models and explain them, which is then also generalizable. Well, the person calling doesn't know why, he just knows who. But the more advanced call centers or the more advanced marketing industry, they know it or try to use this algorithm, these solutions. What I've read, it can sometimes be like 60 to 80% extra in revenue. So in short term and long term even can be more. But just something I read, nothing that I can say for sure because I'm not really into the call center research. Yes, if the data doesn't have any confounding factors, then the T-learner and S-learner work perfectly because there is nothing that to skew the results. So your model can directly learn all the relationships. So then the output will be even more correct. The dream data of these treatment estimation models are clinical trial data, which is fully randomized. Because then there is no bias in the data, your data is clean, and your estimations will be good. And you can enrich it with more information, more data from beyond the clinical trial to even go to more generalizability. I think the question is how we would use the graph analysis and the graph visualization with the models to influence decisions. And one thing that these analysis methods and these models can do is already analyze what's been done before and see if things that you did before didn't go as planned and use that to learn from. Instead of just visualizing some data, you can then explain it and try to find the causes of the things that failed and use those causes to reevaluate your policy, reevaluate your decision to create a solution and create a policy that's actually useful and that does the thing that you want to do instead of the thing that you thought it would do. And also more real time, where if you get in some data, you have a policy, you have things or treatments that you give, and then you use this visualization, for example, for the physician to explain it to the patient and the treatment effect to help decision making to see if it's appropriate enough. And then they can combine it with their own expert knowledge to have the final decision. So there is definitely some room there for the application. And depending on the application, you use one of the methods or just everything. The more information you have, often the better your decision. Yeah, the thing with both with S-learn and T-learners, kind of depends on the amount of confounding and the amount of data that you have. For example, if your treated group is really small compared to your non-treated group, I would advise, for example, to use a T-learner, because if you use a single model, the model will just only look at, for example, the non-treated group. While with a T-learner, you can split them and make sure that they focus on the group a little bit more. You can try how stable they are. That's one of the best methods, and see how confounded your data is. If it's heavily confounded, then often it S-learners, for example, a little bit better. There are other solutions like X-learner, R-learners that all have their own benefits and drawbacks, which is the thing with most AI models. But the T-learner and S-learner are still one of the most important things, as is, for example, causal trees. That's also one of the useful methods.